So let's talk about a very interesting and a challenging part of surgery, that is neurosurgery. Now, in neurosurgery, the most important topic is head trauma, which I've covered in detail in the head trauma module in the trauma segment. So kindly go through that. I'm not going to be covering head trauma again. It's been covered in detail in the head trauma module. Other than head trauma, there's occasionally one odd question in the entrance exam, and it's usually easy to answer. So we'll cover all those aspects. Even in the college, you're sometimes asked a short note on neural tube defects or on Berry aneurysms. Other than that, no further details are asked in the college exams as well. But those who are preparing for the NIMHANS exam, this is a very, very important module. Okay. So in neurosurgery, the first thing which we will talk about are congenital problems. And in congenital problems, we'll first talk about neural tube defects. So congenital problems, and we are first talking about neural tube defects. Now, neural tube defects, you can either have spina bifida occulta or you can have spina bifida aperta, right? So you can either have spina bifida occulta. This is spina bifida occulta. As the name suggests, it has an occult presentation. So clinically, it might not manifest with overt signs, right? Whereas spina bifida aperta will actually present with clinical features. And there are two main types in spina bifida aperta. You have meningocele and you have meningomyelocele. So we'll talk about all of them in detail. First, let's talk about spina bifida occulta. So this is also known as closed spina bifida. This is also known as closed spina bifida because there is a complete covering there, except the problem here is there is a defect in one or more vertebra. There is a defect in one or more vertebrae, and these vertebrae are not closed. You can see here, as you can see in this image, this vertebra is open from here. It is not closed, right? And that is what leads to this spina bifida occulta. But the important thing is there is no herniation of the meninges in spina bifida occulta. There is no herniation of meninges in spina bifida occulta, and usually the site of spina bifida occulta is marked by a tuft of hair. So you'll have a patient who would either be unaware of this condition, the patient would be asymptomatic, or there would be a tuft of hair in the lumbosacral region, which is where it's most common, marking the site of spina bifida occulta. Now, the diagnosis of spina bifida occulta can be made on an X-ray. So an X-ray a simple X-ray will be able to make the diagnosis. And because these patients are asymptomatic, they don't have any symptoms, no clinical signs, we don't do any surgical intervention in a patient with spina bifida occulta. On the other hand, you have spina bifida aperta, which I've already told you comprises of either meningocele or you have meningomyelocele. So meningocele or you have meningomyelocele. So in meningocele, you can see here that there is a defect in the posterior vertebral arch, right? There is a defect in the posterior vertebral arch and there is herniation of the meninges. So you can see there is herniation of the meninges, but the spinal cord is normal. The spinal cord is not herniated. Right? So spinal cord is not herniated. So it's a posterior vertebral arch defect. It's a posterior vertebral arch defect. And there is herniation of the meninges. Herniation of meninges, but spinal cord is normal. And you know that the meninges will encase the CSF, right? And CSF is a clear fluid. So if you have a clear fluid which is covered by a membrane, right? And this is fluid, right? This is fluid which is covered by a membrane. So on clinical examination, you know, any fluid-filled swelling, there would be fluctuation. We've discussed this many times. So there would be fluctuation. And if you have clear fluid there, if you have clear fluid, then it is going to be brilliantly transilluminant. It is going to be brilliantly transilluminant. So those are the clinical findings when you examine a patient with a meningocele. Again, common in the lumbosacral region. So this is what we see when we examine the patient. But how is the patient going to present, right? So the clinical features. So the patient can have lower limb weakness. There can be lower limb weakness which can be seen in these patients. Or there can be bladder or bowel abnormalities. Bladder or bowel dysfunction can be there. In a small group of patients, the fluid might start to leak, the membrane might rupture, and there might be leakage of fluid. There might be leakage of fluid and there can be infection, which can then lead to serious problems for that child as well. Now, to confirm the diagnosis, it's pretty much a clinical diagnosis. You will be seeing that the meninges are bulging out, it's covered by skin. But to confirm the diagnosis, you can do a simple X-ray, which will again show you a defect in the vertebral arch, as we saw in spina bifida occulta. Now, how do we manage such patients? So, of course, this would require surgical intervention, right? And the surgical intervention would be that you want to push the sac back and you want to have adequate cover there. That is the surgical intervention which we require. Now, surgical intervention can either be an immediate repair, and the conditions when you would want to do an immediate repair are if there is a leak, if there is leakage of CSF happening, or if the cord is tethered, or if the spinal cord is tethered, then we do immediate surgery. Otherwise, the patient can have a delayed surgery, especially if the patient is asymptomatic and there is normal neurological function. Right? So this is how we manage a patient with spina bifida aperta. This is meningocele. The most severe type is meningomyelocele, right? Most severe type is meningomyelocele. And you must have read in Obs-Gynae that folic acid supplementation in an expecting mother can cut down neural tube defects by almost 50%, right? But let me share my experience. I was a postgraduate at Safdarjung, and we used to get so many patients who never came for antenatal checkups. They used to come for the first time just for the delivery. And unfortunately, a lot of them never received folic acid supplementation. So we used to see a reasonable number of neural tube defects, and it was a very sad sight to see such a child being born and not doing well after birth. So, I distinctly remember at least 7 to 10 cases which I must have seen in my labor room posting of neural tube defects. Now, the most severe type, in this what happens that there is herniation of not only the meninges, there's herniation of not only the meninges but spinal cord as well. It is the most severe type. And as I have told you that folate supplementation, folic acid supplementation reduces the incidence of neural tube defects. but there are certain drugs which can increase the risk of neural tube defects. And I'm sure you've read these drugs in pharmacology as well. The drugs which increase the risk are mainly your anti-epileptics. So you have trimethoprim, you have valproate, so you have trimethoprim, valproate, phenobarbital. So these are the drugs which increase the risk of these neural tube defects. Now the clinical features of meningomyelocele, again you will have a fluctuant swelling would be there. You may or may not get transillumination. Usually we can get transillumination here as well. The clinical features of these patients, again there can be lower limb weakness. There can be lower limb weakness, there can be spasticity, and there can be bowel and bladder abnormalities. There can be bowel and bladder dysfunction. Again, X-ray will tell us, an X-ray will tell us regarding the posterior vertebral arch defect which is there. And the management of these patients is surgery. And surgery again would depend on the location and the extent of the problem. Right? But what I want you to know now that in the Western world, fetal surgery has become the treatment of choice for neural tube defects, especially meningomyelocele, and that has improved the prognosis dramatically for these neural tube defects. So fetal surgery is when the fetus is in utero, that's when the surgery is done, and then you do the surgery, you close the uterus again, and then the child undergoes the normal birth or cesarean later on. What I mean to say is that the birth happens later on. Fetal surgery has become the treatment of choice for this condition. So this was regarding neural tube defects. And I've already shown you the defects. Here you can see this is just meningocele and this is meningomyelocele where the spinal cord also herniates out. This is a normal vertebra. If there is a defect in the posterior vertebral arch, that is what is going to give rise to these problems. A common short note which is asked in the college exams. Moving on to other congenital anomalies. So let's talk about Chiari malformations now. So let's talk about the next malformation, that is Chiari malformation. Now Chiari malformation can either be a Chiari 1 or Chiari 2 malformation. Chiari 1 malformation is when there is displacement of the cerebellar tonsils into the cervical canal. So displacement of cerebellar tonsils into cervical canal and more than 5 millimeters, right? More than 5 millimeters displacement, downward displacement is there. And this condition is usually going to manifest in adult life, right? Doesn't manifest during childhood or infancy, it manifests during adult life, can be associated with syringomyelia. But there is no hydrocephalus in these patients. There is no hydrocephalus. So as I told you, the manifestation is going to be during adult life, and the clinical features with which the patient is going to present are going to be neck pain. There can be neck pain or there can be bowel or bladder dysfunction. Bowel bladder dysfunction can be there. And to diagnose this condition, an MRI is the investigation of choice. So investigation of choice is MRI here. On the other hand, if we compare Chiari 1 and Chiari 2, in Chiari 2 you can see here that there is going to be hydrocephalus. There's downward displacement of the cerebellum brainstem and the fourth ventricle, because of which there is kinking of the tectal plate and there is kinking in the fourth ventricle, which leads to prominent hydrocephalus in Chiari-2 malformation. And Chiari-2 malformation is going to present in infancy rather than adulthood. So if we compare this, there is caudal dislocation of medulla, that means medulla is pushed down, that is seen in Chiari-2 syndrome. Caudal dislocation into the cervical canal, here cerebellar tonsils are there, whereas in Chiari-2 it is the vermis, medulla and the fourth ventricle, because of which there is kinking of the fourth ventricle and hydrocephalus. Spina bifida may be present in Chiari-1. Hydrocephalus is there in rarely absent, right? In Chiari-2, same is the case for spina bifida, and there is medullary kink also, which is seen in Chiari-2 syndrome. The presentation is in infancy and there is progressive hydrocephalus and respiratory distress, whereas in Chiari-1 there is just cervical pain. Now, Chiari-1 malformation, if there are no major symptoms, it can be managed conservatively if there are no major symptoms, whereas Chiari-2 malformation, here the hydrocephalus has to be addressed. So manage the hydrocephalus. Management of the hydrocephalus is the main treatment for Chiari-2 malformation. Okay. So this was regarding Chiari-1 and Chiari-2 malformation. The final one which we need to talk about is Dandy-Walker malformation. Now, Dandy-Walker malformation is the most common posterior fossa malformation. It is the most common posterior fossa malformation. And in Dandy-Walker syndrome, what happens? There is marked dilatation of the fourth ventricle, right? Marked cystic dilatation of the fourth ventricle. You can see here that the fourth ventricle, there is cystic dilatation. So this leads to hydrocephalus in these patients. There is agenesis or hypogenesis of the cerebellar vermis, right? And there is superior displacement of the tentorium and the lateral sinuses, right? Because the fourth ventricle becomes cystic and it occupies the occipital region prominently, the cerebellar vermis there is hypogenesis and there is superior displacement of the tentorium. Now, Dandy-Walker syndrome. So the clinical features in these patients, and as you can see here, it is well evident that there is going to be a prominent occipital region, prominent occiput. There is going to be macrocephaly. Macrocephaly is the most common symptom in Dandy-Walker malformation. There can be delayed milestones, delayed motor function, and there is hydrocephalus in these children. The investigation of choice is MRI. I've already told you what are the features which we are going to see on MRI, and this condition has a poor prognosis. Management, there is poor prognosis in these patients, and the management is mainly aimed at hydrocephalus correction. So hydrocephalus correction is the mainstay of treatment in Dandy-Walker syndrome. So this was regarding the congenital malformations which are seen in neurosurgery or in the CNS. The next thing which we need to talk about are cerebrovascular accidents. Now, cerebrovascular accidents and stroke have been covered in detail by Dr. Rakesh as well in his lectures. So you know that these cerebrovascular accidents, the cerebrovascular accidents can either be ischemic in nature or they can be hemorrhagic in nature. Ischemic are more common than hemorrhagic. Almost 80 to 85% of the cerebrovascular accidents are ischemic in nature. And ischemic can also be embolic or thrombotic. Right? Hemorrhagic, you know the various types of hemorrhages. This we've discussed in head injury module as well. You can either have an intraparenchymal bleed, You can have subarachnoid hemorrhage, there can be EDH, extradural hemorrhage, or there can be subdural hemorrhage. Now, I've already covered EDH and SDH in detail in head injury. Intraparenchymal also in trauma, I've told you about contusions. There can be intraparenchymal bleeding, which can be associated with hypertension. So these hemorrhagic cerebrovascular accidents are mostly associated with hypertension. Due to hypertension, there's rupture of small arterioles which can give rise to these conditions. And the most common site where this is seen is the basal ganglia and in the basal ganglia, the putamen, right? So that is where this is seen. The localization of these strokes has been covered in detail by Dr. Rakesh in the medicine modules. So for localization, kindly refer to that module for details. What we have to talk about in detail here is about subarachnoid hemorrhage. And subarachnoid hemorrhage, now subarachnoid hemorrhage can either be traumatic or it can be secondary to rupture of Berry aneurysms. Or it can be secondary to rupture of Berry aneurysms. Now, trauma is a more common cause of subarachnoid hemorrhage than rupture of Berry aneurysms, but majority of subarachnoid hemorrhages in trauma are managed conservatively. So majority of them are managed conservatively. Only those which are very large and symptomatic would require surgical intervention. Unlike Berry aneurysms, where if there is a subarachnoid hemorrhage, it usually requires a surgical intervention. Here, traumatic subarachnoid hemorrhages, majority can be managed conservatively. Now, what we need to discuss in detail are Berry aneurysms, right? Berry aneurysms are the ones which are giving rise to these subarachnoid hemorrhages. And you know, these Berry aneurysms are saccular aneurysms. These are mainly saccular aneurysms which are formed at the junction of various vessels in the circle of Willis. So you know, this is the circle of Willis. This is what forms the circulation in the brain, and in circle of Willis, you need to know what is the most common site where Berry aneurysms form. Now, the most common site is at the junction of the anterior communicating artery and the anterior cerebral artery, right? This is the most common site. This has been asked many, many times in the exam. You should be aware of this. The second most common site, there are different answers written in different books. Some say it is the middle cerebral artery and some say it is the posterior circulation, which is the second most common site. Fortunately, this has not been asked in the exam. You should stick to the most common, that is at the junction of anterior communicating and anterior cerebral artery. What are the risk factors for these Berry aneurysms to form? Now, the risk factors, you know, are adult polycystic kidney disease, Ehlers-Danlos syndrome, and increased hypertension can also give rise to these Berry aneurysms and can lead to rupture of these aneurysms as well. Smoking also contributes to these aneurysms, and Marfan syndrome patients and fibromuscular dysplasia patients are also more prone to developing these aneurysms. Now, you know that Berry aneurysms are the most common intracranial aneurysms. We've already discussed the most common extracranial aneurysm, you know, is seen in the infrarenal abdominal aorta. That question has also been asked so many times in the exam. But these are the most common intracranial aneurysms, and the lining of these aneurysms the lining of these aneurysms is formed by thickened hyalinized intima. So thickened hyalinized intima is the one which forms the lining of these aneurysms. And when these aneurysms rupture, another thing which you should know, that the most common site of rupture is the apex. So apex is the most common site where these aneurysms are going to rupture. And when the rupture happens, it can give rise to, if there is a rupture which happens, it can give rise to subarachnoid hemorrhage, or it can give rise to intraparenchymal hemorrhage as well. Okay. So either subarachnoid hemorrhage or intraparenchymal hemorrhage, and we are talking about subarachnoid hemorrhage here. So you know that if an aneurysm ruptures and there is subarachnoid hemorrhage, what will be the clinical features here? The clinical features, you know, are going to be a thunderclap headache. This is the key word which you need to look at in the MCQ or in the clinical vignette. Thunderclap headache is how the patient is going to present. The patient is going to say that he's having the worst headache of his life, and it is going to be sudden onset. So worst headache of life, it's going to be sudden onset. What you need to remember, that focal neurological signs are usually absent. Focal neurological signs are usually absent initially. There can be neck stiffness which can be seen in these patients, right? So sometimes it can also confuse the clinician with meningitis because of the neck stiffness and the sudden onset nature. So that can sometimes be confusing as well. There can be vomiting associated also. Now, some patients might have prodromal symptoms before the actual symptoms start. So prodromal symptoms can be there. And there are certain syndromes also which can be associated with it. You can have Terson syndrome. There can be Terson syndrome. Terson syndrome is subarachnoid hemorrhage plus vitreous hemorrhage which can occur. If there is a middle cerebral artery aneurysm, then the patient can have pain behind the eye. Then there can be pain behind the eye as well in these patients. Now, I've told you the clinical features, right? The key is, how do we make the diagnosis in these patients? So the diagnosis when the patient presents, the investigation of choice is an NCCT. So please remember this, investigation of choice is an NCCT, and there is a Fisher grading on NCCT, right? This Fisher grading on NCCT, grade 1 is when no subarachnoid blood is detected. 2 is diffuse or vertical layers less than 1 millimeter thick. 3 is localized clot or vertical layers more than equal to 1 millimeters. And 4 is intracerebral or IV clot with diffuse or no SAH. Now, this Fisher grading has not been asked in any of the regular entrance exams except for NIMHANS. So mainly details should be remembered by those who are preparing for the Central Institute or the INI CET exams now. So you can see here the Fisher grading, the 4 grades which I've told you, just on CT you can observe them. Now supposing the CT turns out to be normal, or the CT is not available in a hospital, right? Then in that case, what do we do? So if CT turns out to be normal and if there is still a high index of suspicion, or if CT is not available, we will do a CSF tap. And on CSF tap, you will see xanthochromic CSF. So you'll see this slightly yellowish kind of CSF and you need to compare it against white light to make out the difference. This is normal CSF. This is xanthochromic CSF. This is also an indicator that there has been an SAH, right? But you should remember that the investigation of choice still remains NCCT. And I've told you about the Fisher grading as well. So when we examine such a patient, there are two grading scales. Once you've made the diagnosis for SAH, there are two grading scales. You have the Hunt and Hess and you have the World Federation of Neurosurgical Societies score. Right? So you should remember the names. Again, the details have only been asked in the NIMHANS exam till now, but those who are preparing for the ionized CAT exam should know the details of these two scores. So when we talk about the Hunt and Hess score, one is when there is just mild headache, present here. 1A is when there is a fixed neurological deficit seen. 2 is moderate to severe headache, or there is a cranial nerve palsy or nuchal rigidity seen. 3 in Hunt and Hess is lethargy, confusion, or a mild focal neurological defect. 4 is stupor, hemiparesis, or early decerebrate rigidity. 5 is when there's coma, decerebrate rigidity, or the patient is moribund, right? So progressively you can see that the severity is increasing. The World Federation of Neurosurgical Societies, grade 0 is an intact aneurysm, grade 1 is GCS 15, grade 2 is 13 or 14 with no motor deficit, 3 is 13 or 14 with motor deficit, 4 is 7 to 12 with or without motor deficit, and 5 is 3 to 6 with motor deficit. So as you can see that the WFNS is a more objective score than the Hunt and Hess score, right? So you should remember the WFNS scale and remember the term Hunt and Hess for subarachnoid hemorrhage. Now the key is, how do we manage these patients? So the management of these ruptured berry aneurysms, once the diagnosis has been made, it can either be through interventional radiology, and this is coming up as a big branch now, especially neuro interventions. So interventional radiology, there can be coiling which can be done. So you can do an angiography and you can do coiling of the aneurysm, or if we are planning the patient for surgery, then we have to clip the aneurysm. Then clipping of the aneurysm is done. And this is one of the most common emergencies which a neurosurgeon encounters. So in my peripheral posting, when I was posted in neurosurgery, must have seen at least 6 to 7 of these cases where clipping was done. And I fondly remember one case which I'll just tell you when I talk about the complications of these ruptured berry aneurysms. Now the complications, once you've done a surgery or you've managed the patients using angioembolization or coiling, coiling is that there can be rebleeding, of course. So there can be rebleeding in these patients, or these patients can develop hydrocephalus, which is usually a communicating hydrocephalus, but hydrocephalus can form. But the most dreaded complication which a neurosurgeon dreads is a delayed ischemic neurological deficit. And this basically happens because of spasm of the vessels, right? So the main cause is spasm of the vessels. And this can be seen between 2 to 10 days of the surgery. So once the surgery has been done, rigorous monitoring of these patients is done, because a lot of times what happens that these patients are recovering well, everything is going on fine, they've been extubated, doing well, and suddenly because of the spasm they'll become comatose or their GCS is going to deteriorate, and by the time you realize it, the patient is gone. Right? So this is a major complication a dreaded one, and to prevent this spasm, nimodipine can be used in these patients. Distinctly remember one patient, and this was a young male who had polycystic kidney disease. He was in his late 30s. He'd come with a ruptured aneurysm, and in the night time, this aneurysm was clipped, everything, the surgery went off well. The patient was extubated. Next day, he was doing fine. The day after that, he was much better, responding to commands. The family came and met the patient in the ICU. And suddenly, on the third day, the patient within, we took the rounds, everything was fine. And after some time, the nurse gave us a call and said that the patient's GCS has deteriorated and he slipped into coma. And there was no rebleed which occurred, so it was most likely spasm which led to this delayed ischemic neurological deficit. So these are the complications, and this was regarding Berry aneurysms and subarachnoid hemorrhage. The next thing which we need to talk about are brain abscesses now. So brain abscesses are commonly seen either because of hematogenous spread. They can either be hematogenous spread for a brain abscess, or they can be direct spread, right? Direct spread is if the infection is due to sinusitis secondary to sinus infection, that can give rise to direct brain abscess as well. Now, when it is due to hematogenous spread, it is mainly seen in the parietal region. It is seen in the parietal region. If it is due to frontal sinusitis, then it is the frontal lobe which is commonly affected. But if it is secondary to otitis media, then it is the temporal lobe which is commonly affected in these patients. Of course, brain abscesses are going to affect which patients? A normal patient developing a brain abscess is uncommon. So this is going to be more common in immunocompromised patients. And in patients with cyanotic heart disease, where there can be a hematogenous spread, a cyanotic heart disease patient, right? So these are the conditions where it is common. How will the patient present to us? So the clinical features with the patient is going to come with is headache. There can be seizures, there can be seizures here, or these patients can have vomiting, or there can be neurological deficits which can be seen in these patients. Again, you will see a ring enhancing lesion on scan. When you do a scan, you are going to see a ring enhancing lesion here. So the investigation of choice is an MRI, and as you can see here, you will see a ring enhancing lesion. A ring enhancing lesion is seen here on MRI, and the management of these patients. So if we talk about the management, if it's a solitary abscess and it is symptomatic, then drainage should be done, plus IV antibiotics. And antibiotics should continue for 6 weeks in these patients, right? If there are multiple small abscesses, then the treatment mainly is IV antibiotics which are given to these patients. Steroids are reserved for these patients only if there is raised intracranial tension in these patients, and anti-epileptics, some people use them prophylactically as well. Otherwise, if there are seizures, then anti-epileptics are also added. This is the treatment for brain abscesses. Now, before we talk about brain tumors, I want to talk about the various brain herniation syndromes, right? Because whenever there is raised intracranial tension, there is a mass effect due to a tumor or a bleed, there can be herniation, right? And these brain herniation syndromes have been asked in the exam frequently, MCQs regarding them. So if you talk about these brain herniations, there can be subfalcine herniation, central herniation, there can be uncal herniation and cerebellar herniation. These are the 4 herniation syndromes which we are going to talk about. So if we talk about the first one is uncal herniation. Uncal, also known as lateral transtentorial herniation, and this is usually seen, uncal herniation is usually seen when there are temporal lobe lesions. When there are temporal lesions, that's when uncal herniation is commonly seen, and the uncal and the temporal lobe, the uncus and the temporal lobe are forced through the cerebellar tentorium, are forced through the cerebellar tentorium. That is the herniation which occurs, right? So I want you to see here that the uncus is forced through the cerebellar tentorium along with the temporal lobe. So it's mainly seen in temporal lobe lesions. And in these patients, what is going to happen is that there will be ipsilateral third nerve palsy. So the clinical features in uncal herniation, you will get ipsilateral third nerve palsy. So you'll have a dilated pupil on that side, and gradually, because of sequential compression, it is going to give rise to contralateral hemiparesis. So there's going to be contralateral hemiparesis which would be seen in these patients. This ipsilateral dilated pupil is an early sign. This is an early sign because of the compression of the third nerve, and then late signs are contralateral hemiparesis. There will be ptosis in these patients. Third nerve palsy, I've already told you. And a very interesting condition which develops here, very late in the case, there can be ipsilateral hemiparesis also which develops, right? This ipsilateral hemiparesis, this is due to Kernohan's notch syndrome. This is due to Kernohan's notch phenomena, and I'll just tell you about this Kernohan's notch phenomena in a minute. But because of this downward herniation, there can also be durate hemorrhages. And this question has also been asked in the exam. So these durate hemorrhages are due to increased intracranial tension. This is due to increased intracranial tension, downward herniation. Downward herniation leads to stretching of these small, downward herniation leads to stretching of these perforators. So downward herniation leads to stretching of perforators of the basilar artery, and this gives rise to hemorrhages in the ventral or the paramedian brainstem. Ventral or paramedian brainstem, you can get durate hemorrhages. So you should know about this. This has also been asked in the exam. Now coming to Kernohan's notch phenomena, I've covered this in the head injury module as well, but I will cover it again. So in Kernohan's notch phenomena, what is happening is there is uncal herniation. Supposing there is, so we are talking about Kernohan's notch phenomena. And supposing we are talking about uncle herniation happening on this side. Okay, let's say that this is the right side. Right, let's say this is the right side, and if uncle herniation is happening on the right side, I told you late sign is contralateral hemiparesis. So we are saying that there is left contralateral limb weakness, because you know that the tracts are going to decussate. Okay, but when this uncle herniation happens, right, it presses on the opposite side cerebellar peduncle. Right, this is going to put pressure on the opposite cerebellar peduncle, and the Kernohan's notch gets compressed there, because of which the motor tracts get compressed on the contralateral side. So there is contralateral pressure on the motor tracts. On the motor tracts contralaterally also there is pressure now. And because of this pressure, because you know the tract is again going to decussate, the patient late sign, a false localizing sign which is seen later on, the patient is going to develop ipsilateral hemiparesis. Okay. And why is this a false localizing sign? Because we know that the tracts decussate. So if the patient has, supposing the patient comes with right-sided hemiparesis only, then we would assume that the problem is on the left side. But in reality, in this patient, the problem is on the right side only. And it's because of the herniation of the right side putting pressure on the left side that there is contralateral hemiparesis, there is ipsilateral hemiparesis, which would ultimately be seen. So this is Kernohan's notch phenomena. This you should know, it has been asked in the exam. This was regarding your uncle herniation. I've already told you the features: blown pupil, contralateral posturing, and it is usually due to a temporal lobe mass. Then you can have central transtentorial herniation, right? Central transtentorial herniation is these patients, you will have displacement of the diencephalon through the foramen magnum, and in these patients, it's usually, these patients come with coma and bilateral small pupils, which would then proceed to decorticate, then decerebrate posturing, and that ultimately leads to brainstem reflexes. There would be respiratory paralysis, which leads to death then. So that's central transtentorial herniation. Subfalcine herniation is usually seen in patients. So subfalcine herniation is seen when there is a frontal, commonly seen when there is a frontal mass. That's when you get a subfalcine herniation. And in this, what happens? So subfalcine hemorrhage is commonly seen in a frontal mass lesion. And if you look at the image, what is happening here is that the cingulate gyrus, right? The cingulate. So if you look at the diagram, what is happening here is that the cingulate gyrus is herniating below the falx cerebri, right? So falx cerebri, and the cingulate gyrus herniates beneath that. This is usually seen in a frontal lesion. And if you look at the clinical features of subfalcine hemorrhage, these patients will usually be comatose, there'll be contralateral weakness, and there'll be an anterior cerebral artery stroke which can develop as well in these patients. Now, cerebellar herniation, there is going to be medullary dysfunction, so respiratory distress, coma, and bilateral posturing would be seen in these patients, and it is the respiratory distress which then leads to death. So these are the various syndromes which are there. Mostly what has been asked in the exam are uncle herniation and subfalcine herniation. What has been asked is uncle is seen in temporal lobe lesions. Subfalcine is mainly seen in frontal lobe lesions. The clinical features of uncle herniation and Kernohan's notch phenomena have been asked in the exam. Now, our aim whenever we are dealing with a mass lesion or when there is raised intracranial tension is to keep the tension under control so that herniation syndromes can be prevented.